next case, we're going to show you a lung with diffuse nodules distributed everywhere. And we typically, in these situations, will execute the high-resolution CT to try to evaluate the distributions of these nodules, to perhaps give us a clue what it could be. What we do know about this is a 72-year-old patient with no melanoma, so metastatic disease in the lung is high in the list. And on the CT, indeed, we see innumerable, small, and most importantly, randomly distributed nodules in a miliary patterns. These are small, tiny nodules. And it is a pattern that we can see in melanoma, pulmonary metastasis. And certain tumor, including melanoma, but also thyroid cancer, renal cell carcinoma, have predilections for this kinds of diffuse pulmonary spread. Here are two images for a 50-year-old woman who had progressive shortness of breath over a time frame of years. The upper lung shows that there's a lot of irregularity at the pleural surface. There's some cystic changes, asymmetric with the right side bigger than the left side. There's some architectural distortion, maybe even traction bronchiectasis that we can see. On the bottom of the lung, we do see abnormality primarily in forms of mosaic pattern where there are areas of more lucid lung and then there are areas of the denser area of lungs. These usually typifies both the parenchymal, but more importantly, also small airway involvements. Now, the effects on the upper lung is much more prominent than the lower lung. So we have a process that is inflammatory in nature because of the mosaic patterns. And over time, it produced upper lung predominance fibrotic changes. And this is a typical example of a hypersensitivity, chronic pulmonary fibrosis. Now, it's a pretty big category. When we talk about hypersensitivity, it includes more specific entities such as Bird's-Fancy's disease, Robert's lung, and other irritants that can be inhaled and cause reactions in our lung. In our next case, the distribution is reversed. We have now in the upper lung relatively minor disease that we can see peripherally, but in the base of the lung, we have this stack of small loose and cystic area, what we call honeycombing. Now, in addition, we can see that there are bronchiectasis, for example, this one right here. All right, these are traction bronchiectasis, and there are distortions of the lung architectures. And these patterns are usually seen in what we call usual interstitial pneumonia. Now, there are actually many etiologies that cause this pattern. The most common one we think about is idiopathic pulmonary fibrosis. It can also be seen in patients with asbestosis, that is after asbestos exposure and then progress into pulmonary disease. There are certain drugs such as amiodarone is also known to produce this kind of fibrotic reactions in the lung. Now, switching from chronic to acute, I show you here a section image of a patient who just had a severe blunt trauma in the chest after a motor vehicle accident. Right off the bat, we can see there's a pneumothorax on the left side. So these are residual to the trauma itself. What we see in the lungs are multiple consolidated area, but they have a very fluffy appearance. And many of these areas contain loose and cystic structures inside. These are respectively pulmonary hemorrhage, as well as pneumatocele, post-traumatic pneumatocele, that is a collection of gas caused by tears of the pulmonary tissues itself. Now, the clinical setting should be obvious, and typically in this case, we'll see pretty severe rib fractures and other traumatic evidence. And when we see this, we have to interrogate the aorta very carefully. The reason is because it is a high possibility that there are vascular injury as well. In the next case, we're looking at a mediastinal mass. This is not a lung mass. This is a large mediastinal mass in a fairly young patient. And on the CT staging in preparations for biopsy, we want to make sure we know where it is, and it is indeed situated in the anterior mediastinum. The mass is big enough that it pushes the SVC, the aortic pulmonary trunk, posteriorly. Now, what is interesting about this mass is that we see a mixture of soft tissue density, calcium in thick cluster and conglomerates of calcium, but also more importantly too is we see fat. There are multiple representations of fat inside the structures. While lymphoma, myeloma, and other metastatic disease in the anterior mediastinum could involve this space, Very few will present this kind of mixture of calcium as well as fat, and this is a fairly typical presentation of mediastinal teratoma. Finally, I present a case here that tied together the vascular disease associated with pulmonary disease. Here's a 43-year-old man with acute onset of chest pain 2 weeks ago, but didn't seek for care until later on when his chest pain got worse. On a CT pulmonary angiogram, we see a filling defect inside a left lower lobe pulmonary artery. And in fact, you can see that this filling defect occluded a branch of the superior pulmonary artery of the left lower lobes all the way out to the periphery of the lung. And turning on the lung window, you see that there's a regions of mixed ground cross consolidations. And this is pulmonary infarct caused by a loss of pulmonary perfusions with PE. Now, if you pay close attention, you can actually see some pleural reactions to it as well. It can either be pleural thickening or local collections of pleural fluids right at the infarcted area. So we had very quickly went through various diseases that can be presented in a CT of the chest.